he had brightened us. I know Joy since 1970 when he joined JMMC Davangere as an MBBS student. Joy was a strategic thinker, a visionary who was brightened, innovative, and creative. He generously gave us his knowledge, his expertise, his skills. All Davangerians who knows Joy will never forget his tamashas, his laugh, etc. And he was a good football player also. I personally miss him a lot, so also the Davangerians. The Bible, the book of Revelation says about the new heaven and new earth that Jesus will wipe away every tear from their eyes, and the death shall be no more. Neither shall there be mourning, nor crying, nor pain anymore. For the former things have passed away, and this is true for the all who trust in Christ. And I believe our dear Joy is now in a much beautiful place with no pain, no sorrow, no tubes, and no wires around him. May God grant him eternal rest. Thank you.
Thank you, sir. Now we move on to Dr. Anil, HOD Anesthesia, Little Flower Hospital. Sir.
Hello, can you hear me now?
Yeah.
Sorry, I had to join you in this fashion because right now I unfortunately got caught up in the middle of a case, which unexpectedly turned up at around 7 o'clock. So I'm sorry. And thank you for inviting me. This has been an honor. But at the same time, it's very painful too. This is the first time I'm attending a meeting of ISA Cochin. And this meeting has to be in memory of my dear Dr. Joy. It's very painful to recall. And for the last 2 months, for all of us who knew who Dr. Joy sir, this was a very trying period indeed. One day we'll be hearing that he's doing well, he's doing okay. The next day we'll be hearing, his lungs are actually worsened. So day by day, for the last 2 months, we have been actually, we've been in a helpless situation. We have been just helpless spectators. We don't know what to do. We cannot do anything actively, except maybe, support moral, just give moral support to his family members, pray for him. That's all we could do. All of us, including consultants, surgeons, administrative staff, everyone who knew him in LF. Everybody, they used to come every day, ask me or somebody else about how he is doing. Because, news about him coming out was rather very little. We hardly knew what was happening. Of course, when he was at tragedy, we had Dr. Jacob, Dr. Rajesh, and all who frequently updated us on his status. Okay. But we were always hopeful that he would come out because he was a fighter. Right from the moment I met him 7 years ago, I knew what kind of a man he was. He was a very jovial man. We had an age difference of approximately 20 years, but that never prevented him from becoming a friend. Though he was so much senior, he was very close to me. He always used to call me as sir. And that too not mockingly. He seriously meant it. Only when he wanted to discuss something very personal, he called me by my name, Anil. Otherwise, He always addressed me as sir. I even asked him why, sir, why do you keep calling me sir? No, that should be a lesson to your juniors. They should always address you as sir. Probably Dr. John might be able to tell you this. And, it was his fighting spirit actually. He was actually a, you know, he was very passionate about life. It is not anesthesia alone. He was passionate about so many other things. He loved traveling. He had actually a very checkered life, not only checkered career. He had a very checkered life right from his school days, his life in Davangere, then his PG life in Ahmedabad, where he probably had friendships like Dr. Vandana's. Then his career in Libya. Then after that, for nearly 30 years, he worked in LF Hospital as a mainstay of our department. He has worked as a consultant. He headed the department. He was deputy superintendent of the institution. And even when he was 70, he used to be the youngest and most energetic member of the team, I can assure you. We were youngest, we people who are younger by far in years to him, always used to wonder at his energy, even in the middle of the night. That is something tremendous. I'm sure we'll all miss him. In fact, I had prepared a rather elaborate eulogy for him, but words actually choke me. So I feel I can only say we'll miss him sorely, dearly, and may his soul rest in peace. Thank you.
Thank you, Dr. Anil. That was a very emotional talk. Now we move on to Dr. John Abraham, the urologist from the hospital. Over to you, sir.
Sir, please unmute. John, sir.
Dr. John, you have to unmute.
Yeah. Okay. Good evening, all my dear friends and all of my dear anesthesiologists and all our dear friends. It's very painful, to just say all these words. But then I thought, as a colleague who really knew him and adored him, Joy sir, when I came here about 14 years ago, the passion that he had for life and for surgery and anesthesia, that was beyond compare. I'm reminded of a song lyric, they say people come, they say people go, but this particular diamond was extra special. He was truly a diamond. There was never a dull moment when our dear Joy sir was around. He used to say all these stories and about what happened yesterday, what is happening today, and what might happen tomorrow. All these things, we used to just, he used to make the theater such a pleasant place to work in. He used to hold the hand of the juniors and give them the confidence to tackle serious, difficult cases, even as surgeons. He used to just, Saravilla, you just take your time, because I was a greenhorn trying to find my feet in urology. And, he used to just, that is something, a support, like you can call it a father figure or a friend in need, a shoulder to cry on. He was everything, he was all of these. Apart from anesthesia and surgery, he had a zest for life, like football and music were something which was so dear to him. We used to talk about Messi and his exploits, and about Kishore Kumar, Jim Reeves, Rafi. He used to sing all these songs in between. He used to, and another thing is his respect for people, especially for juniors. He used to call us, like every day he used to come in the early morning and say, Vandanam Periyavargale. he used to just, just welcome us, so that we were all so small. He was such a senior chief of anesthesiologist, and I was really humbled. Like everybody who has experienced his touch can never forget him. It was always like that sweet 17. All the time he was in his mind. He was still that dashing young boy who was in search of the football, and like that sort of life, that zest for life is something which is very infectious. And what can I say, like from the division of urology, and from the division of surgery, as representing all my colleagues in surgery and everybody, it's a painful adieu to our dear Joyce. A man of pure joy has left us for the eternal abode. Again, I repeated, people come and people go, but this particular diamond was extra special. Thanks a lot for the opportunity, and wish his soul rest in peace. Praying for his departed, for his soul. Thank you, man. Thanks.
Thank you, Dr. John. That was one side of his jovial side of his personality presented. Now we move on to Dr. Elizabeth, gynecologist from LF. I happened to talk to her in the morning, and by the time we had finished 15 minutes of conversation with her, I was also in tears. So let's hear what Dr. Elizabeth has to talk about Dr. Joy.
Thank you so much, ma'am. Good evening to all the ISA members. And thanks for inviting us over from LF to express what we have felt and what we have experienced with our dear Joy sir. Like Anil sir and John sir said, the last 2 months have been one of the most difficult and terrible times for all of us at LF, because each day we were grappling with the thought that we might lose sir. But like sir said, due to his fighting spirit, we always thought that somehow sir will come through it. That because if I could put sir just in a nutshell and tell what sir was all about, he was full of life. He loved life and he made life beautiful for all around him. And I don't know, sir, he was like, he was full of energy, full of life, and full of positivity, even at the age of 71, which most of the youngsters would actually envy and look up to. Angante oralaayirunnu Joy sir. Now, from an obstetrician, I think John sir told what all he was for the surgeon. And as an obstetrician, I can tell that Joy sir was a pillar of support. I joined about 18 years back at LF as a junior, and now I'm as the head of department. But on all these 18 years through my journey at LF, sir has been such a big pillar of support. In the obstetric emergency, anything in the middle of the night, any postpartum hemorrhage, anything that you think you would lose the patient, sir was there at the head end to tell you, ധൈര്യമായി proceed ചെയ്തോ, തലഭാഗം ഞാൻ ഏറ്റു. This is what he used to tell. You katti vecholu. Even before he used to put in the tube, he will say, katti vecho, baby out agiko. That's what it was. So that much confidence sir had in his skills, and he was such a bold anesthetist. We don't need to think about anything else when we were dealing with a case with him. So that kind of a positivity he used to say. And in the initial years, we often used to get his opinion before closing the abdomen. Close like John sir and Anil sir said, even though I was also 25 years younger to him, he used to address me only madam in front of my juniors and inside the OT. Though we used to make fun about each other, pulling each other's legs, calling all sorts of, just like sir said, Sundaran, Sumugan, 17 Vaisagaran, Purna Garmadi. All we used to call him also, and he used to make fun of us also. But that was the kind of positivity that he gave in the OT. And sir was, I can't tell you what sir was to the LFOT in general, and I'm sure that each of the OT staff will reverberate the same feelings that the three of us have expressed here. That sir loved life. Sir had so much positivity, so much fun, so much happiness inside him, and he spread that happiness to everybody. Sir പറഞ്ഞ പോലെ തന്നെ നമ്മളെ കണ്ട first thing വണക്കം അമ്മ, എന്താണ് ഇന്നത്തെ കേസ്, എന്താണ് ഞാൻ ചെയ്തു തരേണ്ടത്, that much. Even at the middle of the night when you take the case at 10 p.m. and also an obstetric fetal distress or anything like that, he had the same positivity. to end, I think what will really plague my mind was the last Monday OT sir did with me. That was his last working day. And there was the OT ran quite late. Actually, sir was on duty. I still remember there were 3 cases post 6 p.m. And there was not like രണ്ട് OT simultaneously അപ്പുറേ കയറ്റി തന്ന് നമുക്ക് എൽസത്ത് മാഡത്തിന് 10 മണിയാകുമ്പോഴെങ്കിലും പറഞ്ഞു വിടണം എന്ന് പറഞ്ഞാൽ അങ്ങനത്തെ തിരക്കിൽ, in spite of the fact that he was tired. I think he had the COVID symptoms at that time. He had little bit of cough and he was tired. പക്ഷെ എന്നാലും സാറിന്റെ എനർജിക്ക് ഒരു കുറവും ഇല്ലായിരുന്നു. എത്രയും പെട്ടെന്ന് sir wanted us to finish the case, since we had started the OT in the morning. So that much. And he was, at that time also he asked, എന്നാ ഓട്ടിക്കാരെ കൊണ്ട് ഒരു കട്ടൻ ചായ ഇടിച്ചാലോ മാഡത്തിനെ ഒന്ന് ഉഷാറാക്കാൻ. That's the kind of positivity that he gave to each of us in the theater, to everyone. Junior ആയാലും ശരി, senior ആയാലും ശരി, sir was the epitome of strength, love, affection, care. I can't tell what he was to us. That was what sir was. That was his last OT in LF. And that day, I don't know, in so many years, for the first time, we sat together, and after the last case, he told me, Elizabeth, I might think of stopping. Maybe ഞാൻ ഇനി മാർച്ചിലേക്ക് നിർത്തും, he said. And I said, as usual, I used to call him, സുന്ദരൻ സുമുഖൻ 17 വയസ്സുകാരൻ. അത് കൊള്ളാം, സുന്ദരൻ സുമുഖൻ 17 വയസ്സുകാരൻ ഇപ്പൊ നിർത്തിയ ആരാ പിന്നെ ഇവിടെ നടത്തുന്നത്? Like that, I smiled and asked him. But then I don't know, maybe that God had decided beforehand that it was time for sir to end. But then, whatever said and done, sir's life will remain very, very strong inspiration for us to stay strong, to stay full of happiness and spread happiness to everybody around. Thank you so much, ISA, for letting us open up our hearts about sir. And what actually, if I tell you just one thing before I end, what actually felt hurt or was breaking our hearts was the kind of burial or whatever, the farewell that he got because of the COVID protocol. Sir was like a vibrant personality, and he deserved a better funeral. That's what will plague all our minds, that we couldn't give a fitting farewell. And I thank ISA for at least for this opportunity, that we could all remember sir and actually give some peace to his family and to people who knew him, that sir didn't deserve this kind of death, whatever said and done. But anyway, God's will. I'm sure, like all of us said, that sir is resting in peace, in heavenly bliss. And definitely sir will be smiling as he was smiling in the picture. Thank you so much. I say thank you.
That was a bidding farewell to a great man. Thank you, Dr. Elizabeth. Then we move on to Dr. Vandana, who is a representative from our city branch. Over to you, Dr. Vandana.
Good evening, everybody. Actually, I just can't imagine that I'm sitting here today and talking about Dr. Joy like this. It's very difficult to accept that he's no more. I still feel that somewhere or sometime I'll meet him and we'll again talk and laugh like before. Actually, my association with Dr. Joy goes back to 1983. When I joined Baroda Medical College for post-graduation. He was already there. He was doing PG. He was my senior. And as always, the senior always teaches the junior to do many procedures and all. So he taught me many things. He taught me a lot of tips he gave me. And many things I remember all through these years. One particular thing he used to tell me is that when you're giving spinal, you paint and drape fast, because then you can take time for the procedure. And somehow that stuck with me always. And I still tell that to my juniors. Like, you won't believe it, that every time I've given a spinal or done a procedure, I think of him. Whether in between we lost touch after he left Baroda. But again, we met here after many, many years. But I could not forget him. He was such a cheerful, vibrant, very positive person, like what others have told. He was like that even then. And the professors used to just love him. They used to really, and they still remember him. Last few days when I've been telling them about his condition, they've been really worried. And I could see that our professor, she's almost 90 now, she almost broke down when I told her the sad news. And so it was impossible to forget him, though we were not in touch in between. And many years later, in 2000, when we shifted to Ernakulam, he was the one who gave me a break in LF. He was HOD at that time. And I will be ever grateful to him for that. In all these years, he had not changed one bit. He was the same cheerful, happy, very positive person, always joking. And it was impossible to sit next to him and not smile or laugh even. And I really miss him so much. We used to travel together most of the days. While I was working in LF, we used to travel together most of the days by car. The journey used to just fly by in a like you never would know when you left and when you reached LF. All throughout, he would tell me stories about PG days, about talk in general, give me life tips, tell me you do this, do that, like useful tips. And I can never forget those days with him. I remember one day he had some chest discomfort from morning onwards. We went together, and then he took some Digene, and he took some pantoprazole, and he took an ECG that was okay. There was some bradycardia. We came back together also at 5 o'clock in the evening. I dropped him on the road in front of his house. And then later next day, I came to know that he actually had an MI that day. And he had an angioplasty. With God's grace, I was very worried that, there would be a problem. With God's grace, he survived that and went on for so many years. And without any change in his personality or anything. I mean, if I go on talking, I can say quite a lot about him. And really, it is with a very heavy heart that I'm saying all this. And I'll really, really miss him. I wish I could just meet him at least once more. My deepest condolences to his family members. And I don't know what to tell them for this irreplaceable loss that they are going through. Thank you.
Thank you, Dr. Vandana. May his soul rest in peace, and we continue to pray for the bereaved family. Now we move on. Before we move on to the academic session, it is my privilege. It is my pleasure to announce that Cochin City branch is holding ISA Midcon 2021 PG Quest and midterm CME on a virtual platform on 21st and 20th and 21st March. This is organized by ISA Kerala State Chapter and sponsored by ISA National. Registration is free up to March 25th. All are welcome to the conference. Now we move on to the academic session. Academic session is conducted by Lizzie Hospital, Kochi, and we have two topics. First is CPR, over the years by Dr. Vandana, Senior Consultant, Department of Anesthesiology, LISI. And the second topic is too much, too little, or just about even. Time to use IV fluids as drugs by Dr. Rajiv K, HOD, Department of Anesthesia, LISI Hospital. Session is chaired by our Honorable Secretary, ISA Kerala State Chapter, Dr. Benil Isaac Matthew. Welcome, Benil. Dr. Benil to chair the session.
Thank you, Madam.
Over to you.
Honorable State President, Dr. E.K. Abdul Nasser, City Branch President, Dr. Shalu Aib, City Branch Secretary, Dr. Prema Anthony, past National President, Dr. Chakra Rao, past State Presidents, Dr. Tampi Matthew, Dr. Eban, and Dr. Austin Pice. Warm good evening. Before moving on to our academic session, a small correction which Madam told. Our registrations for ISUMMITCon will be free till 20th of February, not 20th of March. So
Oh,
please do
okay.
register before 20th of February itself.
Sorry.
And I thank all our colleagues and all our ISA members for the overwhelming response which they have given to us when we have asked for a help or when we have asked for a contribution for the treatment fund for Joy sir. So thank you all for the support. We could collect a total of 15 lakhs as Nasser sir told you all. And out of the which includes 4 lakhs from ISA Cochin City branch. So thank you ISA Cochin City branch for their good work. And about today's speakers, our first topic is, as Madam told, that is CPR. And the speaker is our Vandana Madam. Vandana Madam does not require any introduction for Cochin City branch members. Madam is the past secretary and past president of ISA Cochin City branch. And at present, she is a senior consultant in anesthesiologist in Lisi Hospital, Cochin. She did her MD from Baroda Medical College, and her interest area of interest are academics only. So nothing more to tell about her. So we'll move on to our academic session. Over to you, madam. Thank you.
Can I share my slides?
Yeah, please share.
Okay. Is it seen? Are my slides seen?
It's visible, madam, and you are audible. Perfect.
So, good evening, everybody. The topic of my presentation today is CPR over the years. So, a few months back, I came across an article in the August 2020 issue of Anesthesia Analgesia, where they had described how the Resusci Annie, which is the cardiopulmonary resuscitation simulator, came into existence. Now, the story goes like this. It was the 19th century in France, and they found the dead body of a young, beautiful lady in the river Seine. They could not identify who it was, and the medical examiner asked a death mask to be made out of plaster cast. Now, she was so beautiful that this death mask became very popular in the 1920s and the 1930s, and it was it was a great inspiration for artists, musicians, and for popular culture. But nobody could find out who this lady was, and they named her the L'Inconnu de la Seine, meaning the unknown woman of the Seine. Now, forward to a few years, at the Scandinavian Society of Anesthetists, Peter J. Safar, who was a renowned anesthesiologist and one of the pioneers for mouth-to-mouth resuscitation, he was introduced to a Norwegian toy maker, Asmund Lerdahl. We are all familiar with Lerdahl, and he approached Lerdahl for help in making training mannequins to spread the knowledge of mouth-to-mouth resuscitation. And Lerdahl, for the face of this mannequin, he chose the beauty of the Incarnate. And the Resusci Annie was created in 1959-1960, and this was the beginning of simulation in modern medicine. Now, artificial respiration actually goes back to the 16th century with Vesalius' work on artificial respiration in living animals. In 1732, in Scotland, William Tossack relieved a suffocated coal pit miner using mouth-to-mouth breaths. And in Paris in 1740, they officially accepted mouth-to-mouth resuscitation for reviving drowning victims. There were a lot of innovation. Bellows method was used by Swiss physician Paracelsus for artificial respiration. A London physician, Marshall Hall, in 1856, alternately changed the position of a patient to provide artificial respiration. 2 years later, another London physician, Henry Sylvester, described a method where he lifted the arms above the head of the patient and then crossed the arms over the chest for expiration. These methods remained in vogue until the early 20th century. And in 1956, Dr. Elam and Dr. Peter Safar, about whom we talked earlier, he proved that mouth-to-mouth resuscitation was beneficial. This is a picture of Dr. Safar demonstrating mouth-to-mouth resuscitation. Regarding chest compressions, earlier in Germany, in animals in 1870s, it was demonstrated. And it was also demonstrated in 2 young humans in 1891, also in Germany. Defibrillation was discovered in 1775 by a Danish veterinarian who could restart the heart of a lifeless chicken. In 1947, this was tried on an exposed human heart successfully by Dr. Claude Beck. And Paul Zoll, he demonstrated the uses of an external defibrillator around the same time. Now, coming to the first portable external defibrillator that was unveiled by Dr. Cowan Heavens' team at Johns Hopkins. Only problem was this was 200 pounds heavy. In 60, his team, which included Dr. Safar, combined mouth-to-mouth breathing with chest compressions, and this created the CPR, which was a forerunner of our present resuscitation methods. AHA was already formed in 1924, and they started training physicians around this time for a closed chest cardiac resuscitation. Resusci Annie was born in the same year, so widespread training could be imparted. In 66, the first CPR guidelines were published, and after that, periodic guidelines have been published at regular intervals till the present date. Pediatric BLS, ALS, and neonatal resuscitation was introduced in 88, and in 1990s, the public was trained by providing public access defibrillation programs. Now, all this was conducted by the AHA or individual groups of cardiologists. But in 1992, they decided to have a common committee on resuscitation. And so the ILCOR was found. And they decided that they should have a unified resuscitation guideline, which they came up with after 8 years. Now, this standardized the CPR methods worldwide, and this is the one which is being followed now. Every 5 years after that, updates, new guidelines have come up, and updates have also come in between. Now, coming to the first international guidelines. In this, the concept of chain of survival was introduced. It consisted of 4 links. One was early access, early CPR, early defibrillation, and early ACLS. The first 3 links were very crucial. They were mostly performed by lay responders. And any break in this chain, in the first 3 links, could affect the chest compression, rate, depth, and ratio were determined. In 1992, about 80 to 100 compressions were recommended for adults and children, and 120 compressions for infants. The rate was increased and was unified to 100 times per minute for adults and children in 2000. So let us look at the other aspects about the compression ventilation ratio. In 1992, it was 5:1 for the lone rescuer and 15:2 for 2 rescuers. In 2000, this was fixed at 15:2 for whether it was a lone or 2 rescuers. The standard of compression depth was measured by the change in shoulder level of a rescuer, and this was changed to the depth in victim's chest by 4 to 5 centimeters. Look, listen, and feel came to be the method for assessment of breathing, and rescue breathing had to be delivered if they could not find any of these components. Many of the senior members will be familiar with the precordial thump, which was used in earlier days as a beginning of resuscitation. This recommendation was removed in 2000. About defibrillation, as I already told, since 1990s, the AED was already in widespread use, and it was recommended in 2000 that a stacked sequence of 3 shocks should be administered without giving chest compressions in between. So about the drugs, amiodarone and procainamide replaced lidocaine as first-line agent for tachyarrhythmia management. Amiodarone and sotalol were recommended for stable monomorphic and polymorphic VT. Bretillium was dropped from the algorithm, and vasopressin came into the picture, and it was recommended that vasopressin can be substituted for epinephrine. Now coming to 2005, there was increased emphasis on high quality CPR. They advocated a push hard, push fast method for effective chest compressions. They said to allow complete chest recoil after each compression and to minimize interruptions in chest compressions. The compression rate was unchanged. It was still approximately 100 per minute in all ages. The ratio changed from 15 to 2 to 30 to 2 for sole rescuers. And they recommended that the rescuers should be rotated every 2 minutes of compression or after 5 cycles in order to reduce fatigue. The 3-shock sequence of defibrillation was changed to 1 shock, followed immediately by CPR. So we are now seeing that there is a lot of importance given to chest compression. So they did not want to interrupt chest compressions in any way. Even to check circulation, they did not want to interrupt chest compression, and they said it should be done only after 5 cycles or approximately 2 minutes of CPR. Regarding post-resuscitation care, myocardial and organ function support after initial resuscitation was recommended by support of blood pressure, control of temperature, blood glucose control, and avoidance of routine hyperventilation. Now, another 5 years later, a newest development occurred, which was very important and very significant. The sequence of steps of BLS changed from ABC to CAB. Now, again, we see that a lot of importance is being given to chest compressions, because they said even before airway is handled, the chest compression should be given. The BLS algorithm was simplified. Look, listen, and feel was removed from the algorithm, and compression only CPR was encouraged for a lay rescuer who was not trained in the detailed CPR methods. There was increased focus on high quality CPR, again highlighting the points which I mentioned before. The significant changes was that the compression rate was changed from approximately 100 per minute, mind the wordings of this, to at least 100 per minute, means at least 100 compressions should be given per minute. The depth was again changed from 1.5 to 2 inches to at least 2 inches. And it was recommended that once the advanced airway was in place, chest compression should continue without cycling with ventilation. So the rescue breaths should be given at about 1 breath every 6 to 8 seconds, which comes to about 8 to 10 breaths per minute. There was no major change in the compression to ventilation ratio in the rescue breath duration, which they said should be given in 1 second, or defibrillation, cardioversion, and pacing. Continued emphasis was given on, was placed on minimum interruptions in effective chest compressions until there was return of spontaneous circulation or termination of resuscitative efforts. They recommended that the lay rescuer should not try to check for a pulse, and even healthcare providers should not take more than 10 seconds to determine if a pulse is present. 2 new parts in ACLS came up. One was post-cardiac arrest care and education, implementation, and teams. A new 5th link was added in the AHA adult chain of survival, which was integrated post-cardiac arrest care. The use of quantitative waveform capnography was a major new class 1 recommendation to confirm endotracheal tube placement, and cricoid pressure was no longer recommended. Atropine was out for routine use in pulseless electrical activity or asystole, but chronotropic agents were recommended if in unstable or symptomatic bradycardia, atropine was ineffective. If it was ineffective, we could use chronotropic agents. And adenosine was recommended for initial management of undifferentiated regular monomorphic wide complex tachycardia. The box and arrow algorithm, which we saw in 2005, gave way to a circular algorithm. And as mentioned earlier, a early post-cardiac arrest treatment algorithm was included. And this included transportation to an appropriate hospital or critical care unit after resuscitation. And the key objectives of this was anticipation treatment and prevention of multiple organ dysfunction. As mentioned earlier, education, implementation, and teams was a new section. Now, going to 2005. Now, 2015. 2015 was actually not a complete revision of the 2010 guidelines. This was more of an update to the previous guideline. By now, mobile phones were widely in use, and the use of mobile phones was advocated to allow the rescuer to contact the emergency response system. There was an upper limit which was defined in the rate and depth of chest compression was defined in adults. Rate was recommended at 100 to 120 per minute, and the depth was between 2 and 2.4 inches or 5 to 6 centimeters per minute. They advise that minimum interruption should be there in chest compression. So even before and after shock, there should be minimum pauses in chest compression. The major changes was that vasopressin, which was added earlier, was removed from this algorithm. Prognostication during CPR was also a very active topic. For example, if they said if the end-tidal carbon dioxide after 20 minutes of resuscitation and in intubated patients was still low, it indicated that the prognosis was bad. eCPR was another concept which came up, but it was only recommended as an alternative to conventional CPR and only in selected patients with refractory cardiac arrest if the etiology of cardiac arrest was potentially reversible after a period of mechanical cardiopulmonary resuscitation. So it was not a strong recommendation. There were no major changes in the oxygenation capnography, although ultrasound was added as an additional method. No changes in defibrillation, and epinephrine, the early use was again strongly recommended. Regarding post-cardiac arrest care, targeted temperature management was recommended in all comatose adult patients with ROSC after cardiac arrest. That means that for a period of 24 hours, in patients who were not responding, they kept the patient at a temperature between 32 and 36 degrees and assessed the patient only after only later on for prognostication of neurological status. Hypotension and hypoxemia were avoided and immediately corrected. And all resuscitated patients who progressed to death or brain death were potential organ donors. The next from 2017, the next 3 years, they came up with focused updates. They dealt with only certain parts of the previous recommendations and updated these parts after some evidence evaluation. So the 2017 update was on only adult BLS and CPR quality. They said that in out-of-hospital cardiac arrest, if the lay rescuers were untrained or they were trained in only chest compression CPR, they should provide only chest compression, maybe with the help of dispatcher or without the help of dispatcher. And if they were trained in both, then they should proceed to provide rescue breaths also. Regarding EMS delivered CPR, it was recommended that EMS providers, before they placed an advanced airway, they should perform CPR. And continuous compression with positive pressure ventilation should be delivered without pausing the chest compression. The next 2018 update was the use of antiarrhythmic drugs. And in this, we see in this algorithm that amiodarone or lidocaine could be considered for refractory VF or VT, and routine use of magnesium was not recommended. In 2019, they updated the use of advanced airways, vasopressors, and eCPR. Regarding advanced airways, what they said that in out-of-hospital settings, cardiac arrest settings where the success rate of intubation was low, or the rescuers did not have proper training for endotracheal intubation, they should go in for a supraglottic airway device. And if they were trained, or they were good success rates, or it was in a hospital setting, they could go for a endotracheal intubation or a supraglottic airway device. And the rescuers should undergo regular training in performing endotracheal intubation. Not much change in vasopressors in eCPR. And they also said that epinephrine should be given for cardiac arrest in shockable rhythm when the patient does not respond to initial defibrillation. Now coming to the latest 2020 guidelines. Now these are all, there are many new recommendations in these guidelines. I'll just quickly go through these. First of all, it was recommended that lay persons should start CPR for presumed cardiac arrest. They should not waste time in confirming cardiac arrest, because the risk of harm to the patient is low if the patient is not in cardiac arrest. Whereas you lose time not giving CPR, you're doing greater harm to the patient. Arterial blood pressure or ETCO2 during ACLS was recommended to monitor and optimize CPR quality, and double sequential defibrillation was not recommended. IV access is the preferred route of medication over intraosseous access, but if IV is not available, you can go in for an intraosseous access. After ROSC, close attention should be paid to oxygenation, blood pressure control, evaluation for PCI, and targeted temperature management, or TTM, which I mentioned earlier. And multimodal neuroprognostication should be followed. That means after targeted temperature management, you should use different modalities to prognosticate the neurological status, and then only you can discontinue support, decide whether you have to discontinue support or not. Other recommendations was that they said that even after initial hospitalization, the recovery from cardiac arrest continues even later on. So the support also should continue for their physical, cognitive, and psychosocial needs. Lay rescuers, EMS providers, and hospital-based healthcare workers should be debriefed after a resuscitation in order to preserve their mental health. Then in cardiac arrest in pregnancy, they focused on maternal resuscitation. I'll come to it a little later. And early perimortem cesarean delivery, that is within 5 minutes of an unsuccessful resuscitation is recommended. So there were some unchanged or reaffirmed points. What they said is epinephrine as early as possible, and use of audiovisual feedback devices during CPR was also recommended. This is the picture of one of the audiovisual feedback devices, which gives you feedback regarding your efficiency of your cardiac compressions. Now, one more link, a sixth link, recovery, was added to the chains of survival. This link dealt with the post-resuscitation support, which I mentioned earlier. There were enhanced algorithms and visual aids. Another algorithm is this algorithm in which epinephrine, early administration of epinephrine was stressed upon for non-shockable rhythms. Two new opioid-associated emergency algorithms were added. The post-cardiac arrest algorithm updated was updated to emphasize the need to prevent hyperoxia, hypoxemia, and hypotension. And this is a new diagram for neuroprognostication. I'm not going into details, but I've already mentioned a few things about it: the targeted temperature management and the prognostication. Now, coming to the cardiac arrest in pregnancy algorithm, the main stress is on oxygenation and airway management, because these patients are very prone to hypoxia. They recommend that the fetal monitors should be detached when you're performing obstetric interventions, because this may divert your focus from maternal resuscitation. Targeted temperature management, again in the comatose patient. At this time, fetal monitoring should be undertaken. and perimortem cesarean delivery should be considered, as I mentioned earlier. Now this is now we come to the present. This is not a recommendation; it is just under evaluation. This is an AED drone, and they have been doing some studies to see whether the drone will deliver the AED faster to the rescuer when the rescuer asks for help. So, and they have done some studies, and they have actually found good positive feedbacks, and they have found that the emergency team always reached after the AED. For locations 6.6 to 8.8 kilometers away, the margin was 2.1 to 4 minutes faster for the AED. And when it was studied against paramedics, it was found that the drone reached earlier by 7 to 8 minutes. So definitely each minute counts in cardio in CPR, and let us see what happens in the coming years. We have come a long way from the 1600s, where they experimented on animals with ventilation, to the present era of drones, and maybe in the next recommendation we will see a recommendation regarding drones. Thank you.
Thank you, madam. It was an excellent presentation, and madam explained the history, the entire history of CPR very nicely. Thank you very much. And now the topic is open for discussion. We got one question in the chat box. Shall we take up the question in the chat box, madam? The question is from Dr. Murali. Why high heart rate is effective in CPR? Madam?
Yeah. So basically, when you're giving a CPR, you have to maintain proper circulation to the brain, and so you have to give at a higher heart rate in order to maintain the circulation.
And the second question is CPR rate in pediatric patient for single and multiple rescuer.
Yeah, pediatrics, actually, I'm not very familiar with the recent recommendations. I didn't go through the
Madam, it's same only. It's 30:2 for a single rescuer, and for two rescuers, it's 15:2 in neonates. And pediatrics, it's 30:2. And any changes recommended in COVID era?
That also I'm not very familiar, except for the COVID precautions. I don't know whether there are any particular changes in the COVID era.
I think if seniors want, they can join us. If Suresh sir is there, he can add something. Sir can help.
No, as far as COVID is concerned, there is only precautions that they have, only changes in recommendations that how you approach the patient. There is no change in any of the protocols. You don't jump and give CPR to a patient who is COVID. So you have to be fully covered, and all PPE precautions should be there before you approach the patient. No mouth-to-mouth breathing. And if a person is already there prepared, you continue with the CPR. That is already, we have discussed this many times in the group, I think, when early last March, in May, when things were starting. So otherwise, they have not mentioned any changes in the COVID protocols. I mean, COVID patient getting a cardiac arrest.
Thank you, sir. And there's no more questions in the chat box. And madam, one thing I think actually you didn't mention what happened in India in 2017. Actually, in India, the ISI formed the Indian Resuscitation Council, and they came out with 3 guidelines: COLS and BCLS and CCLS. That we can add.
Yeah.
If there is no more question, we can move to the next presentation. that is too much, too little, or just about even. Time to use IV fluids as drugs by Dr. Rajiv.
Dr. Binil, shall I start
Yeah,
sharing the
please share, sir. Dr. Rajiv is a senior consultant and HOD of Department of Anesthesiology, Lisi Hospital, Ernakulam. He did his undergraduation from Calicut Medical College and did his post-graduation from KMC Mangalore. And he worked at Luth Hospital, Kochi. Then he left to UK for 5 years, then came back and joined Kim's Hospital, Cochin. And now, presently, he is working as a HOD and senior consultant in Lisi Hospital, Ernakulam. Sir, over to you.
Good evening, everyone. Am I audible to everyone?
Yeah, sir, it's audible and the slides are visible. Perfect.
Okay, good evening, everyone. First of all, I would like to thank ISI Cochin City branch for giving me this opportunity to present before everyone regarding the change in IV fluids. Before we go on, one thing that I thought somebody would say about Joy sir is, Joy sir could not have more aptly been named by his parents. I think Joy sir was a pleasure to all who met him or came into his life or crossed paths with him. I had the pleasure of just speaking to sir a couple of times in the ISA meetings or the ISA Cochin City branch meetings, but I've not had an extended contact with him. But I think he couldn't have been aptly more named. May his soul rest in peace. And I'll move on to my topic. It's too much, too little, or just about even. Time to use IV fluids as drugs. Intravenous fluids, as you all know, is the commonest intervention from an anesthetic point of view or as anesthetist. Each patient has different needs and we need to tailor it to each patient. And almost always we err on the higher or the lower side. And the sad part is this use of intravenous fluids impact on recovery and the clinical outcomes of the patient also. So it is time we start treating IV fluids as drugs. And as you all know, all drugs will have a prescription, which is verified daily by our team of doctors, and so should fluids. The main idea about giving intravenous fluids is to maintain the internal milieu so that the cells can function normally on a day-to-day basis. It is not as easy as we say. Before we move on, some common terms like osmolality, and tonicity. Just to cut the story short, osmolarity and tonicity are not the same. Tonicity is the capacity of an extracellular fluid to create an osmotic gradient that will cause water movement into or out of the cell. And it cannot be measured, so otherwise tonicity does not have any unit. Tonicity is determined by the solutes that cannot enter freely. So this is my slide on tonicity and cell behavior. If you actually look at it, when the cell is in the isotonic medium, water moves into the cell and water moves out. If the cell is in a hypertonic medium, the cell shrinks, water moves out, and in a hypotonic medium, the cell swells up and eventually ruptures. This is something that we all learned earlier in our PG days. We have the intracellular fluid and the extracellular fluid, and the distribution of water is in such a way that intracellular fluid is almost 28 liters, interstitial and plasma are almost close to 14 liters put together. And there is movement where there is an input that is taken from water intake through drink and food, and the output is through the kidneys, the lungs, the feces, sweat, and skin. All my talk predominantly is going to be based on this article that was published in the Annals of Intensive Care in May 2020. It is from the International Fluid Academy, and they have prescribed a literal guideline on how to use fluids in the perioperative and the critical care setting. As far as we know, the ideal IV fluid still does not exist. So we have to use it as a drug. So an underuse, an overuse, and it can cause side effects. So overloading the patient with more fluid or restricting fluids are going to have problems with the patient. The main indications for fluid therapy, as you would all know, is resuscitation, replacement, and maintenance. Each one has a way of going on. If it is a resuscitation stage, we are addressing a volume deficit where the patient has got a hypovolemia, which can be due to bleeding or which can be due to the disease pathology in the patient. An existing or a developing deficit due to the disease causes a replacement, which is not correctable orally. So that is why we have to replace it. And stable patients who are not able to drink enough will need maintenance fluids. Something that has been ignored by all of us is fluid creep. That is a terminology that has been started to be used, where drug delivery and catheter patency, we end up using fluids as a solvent for many of our drugs, like antibiotics. They end up getting, like, for example, if a patient is getting 3 doses of antibiotics per day, and each of your antibiotic dose is diluted into 100 ml saline, the patient would get 300 ml added fluid. So we have to add that as the intake of the patient. And there is role for catheter patency being maintained by the fluids continuous infusion. So we have to be aware of the fluid creep as well when we prescribe IV fluids. Just as all drugs, there are indications, there are contraindications, and there are side effects. In the resuscitation phase, it is the idea of rapid restoration of the circulating blood volume. And in replacement phase, we try to mimic the fluid that is lost, depending on where the fluid is lost from. For example, if it is from the GI system, or if it is more of pancreatitis sort of stage, then we decide depending on that. And we also decide on the basic electrolytes and the glucose content of the fluid in the maintenance phase. There is no standard dosing for fluid management as such prescribed, but we try to develop it based on the body weight and the associated comorbidities and the age of the patient. Just like for any other drug, we should have a duration. That is, there should be a trigger for starting and stopping IV fluids. So if there is no need for an IV fluid, we should stop the IV fluids rather than continue it unnecessarily. And there is a role for withholding or withdrawing IV fluids once it is not needed. So we can actually climb down, that is de-escalation, just like what we do for antibiotics. Just like antibiotic stewardship, there is a concept of fluid therapy stewardship that is being introduced recently. Any inappropriate therapy, like for example, you give lot of 3% saline or you give lot of normal saline, you end up having a little bit of hyperchloremia, which can actually lead into acidosis. And it can also, when you actually don't give enough fluid, it can actually lead on to acute kidney injury, which might or might not need renal replacement therapy. So the best part of a fluid therapy stewardship is we should tone ourselves to have an appropriate therapy where patient risk factors, like whether the patient is at risk for a fluid overload, whether if in a case of sepsis, whether there's a source control that has been done, or if the patient has got a capillary leak, or how the patient's kidneys are working and other organs are functioning. So then only it will become an appropriate fluid therapy. On top of that, it is not by just giving an appropriate therapy, it should also be timed properly. So we have to go in for early goal-directed fluid therapy. A combination therapy where you use a combination of, for example, normal saline and ringer lactate, or normal saline and the isotonic solution, they can be less toxic than the using one's fluid alone. Just like any other drug, there is a role for pharmacokinetics and pharmacodynamics and the toxicity of the drug or the toxicity of the IV fluid that we are using. So we should prescribe it for a correct duration, and when there is a role for de-escalation or withdrawal, we should start withdrawing our IV fluid therapy. The main variables that change the pH of body fluids is the plasma protein, the partial pressure of carbon dioxide, the concentration of non-volatile weak acids, and the strong ion difference of the fluid that is given. That is a difference of the sum of all the cations and the anions. So IV fluids will affect the pH of the patient. The electrolyte content, that is the strong ion difference of the extracellular fluid, and also due to the amount of volume or the dilution that is caused by the volume of fluid that is infused. So if the SID of the infused fluid is greater than plasma bicarbonate, the pH will tend towards alkalosis. And if the SID is less than plasma bicarbonate, the pH will tend towards acidosis. The best example is normal saline and ringer lactate. In normal saline, the strong ion difference is very low and it is less than plasma bicarbonate. So you will cause acidosis with that fluid. And on top of that, fluid depends also on the tonicity, the electrical neutrality of the solution, and also the strong ion difference. Now, there is a lot of talk regarding balanced salt solution, why we should use balanced salt solution. The main reason being chloride-rich saline, which for years or for ages has been considered normal saline, is no longer considered normal. So it can cause dose-dependent acidosis and it will lead to hyperchloremia. And it can lead on to a decrease in renal perfusion also, which will again aggravate the kidney function. There is increasing evidence that hyperchloremia compromises the renal function. And by using a balanced salt solution, this dose-dependent acidosis and the abnormalities caused due to the renal function are prevented to a large extent. Saline still holds good when you have a hypovolemic, hyponatremic patient, or when you are addressing a patient with hypochloremic metabolic alkalosis. This fact is, you can see the endothelial cell and the glycocalyx. In the first, you can see the healthy status. The glycocalyx is working properly. The second is when the sepsis, there is gross disruption of the glycocalyx. This can cause rolling and additions of the leukocytes. It leads on to fluid extravasation and interstitial edema. And there are even microthrombosis that are even caused. So an intact glycocalyx and an intact endothelial cell is an essential for normal cellular function. Albumin is the other thing that is, initially it went out 10 or 15 years back, and then now it's coming back again. It's 50% of plasma protein. It's main determinant of the oncotic pressure. And oncotic pressure is a pressure that works against the hydrostatic pressure and causes reabsorption of fluid also. It has got a big role to play in regulation of microcirculation, fluid dynamics, and endothelial glycocalyx layer. As I said earlier, it is the gel-like layer that lines the endothelium. It maintains the vascular barrier and the hemostasis. Pathological processes like sepsis or diseases which can release reactive oxygen species, cytokines or endotoxins, and even hyperglycemia can lead to the shedding of the endocalyx layer. This shedding of endocalyx layer leads on to a failure of the barrier function and will lead on to interstitial edema. The excessive fluid therapy that we do, or the overdosing of the fluid therapy that we end up doing, compounds this deterioration of the barrier function and the cellular edema. So that is why in surgical patients and in healthy volunteers, volume loading does not cause shedding. But in a septic patient or in sepsis shock patients, the shedding is proportional to the volume infused. So we should be careful when we end up prescribing a whole lot of fluids for our patients. The Albios study for albumin has got both for and against albumin. It lowers the risk for death, but in cardiac surgery patients, it can cause more kidney injury. But in general, the saying is when you end up using albumin judiciously, it lowers the risk of death in those patients. Regarding perioperative fluid management, the aim is to maintain an effective circulating blood volume, and the current teaching is to avoid under and over hydration. So a zero balance would probably be the best. Overnight fasting and bowel preparation, we have to try and address as fluid deficits. So it would be worthwhile to prescribe IV fluids during the period of our fasting and bowel preparation, especially for major surgeries. And they did find out that the incidence of post-op complications is far more when the fluid retention is more than 2.5 liters. This is during the perioperative phase. And more people are coming out against the preloading strategy. It doesn't work, it seems. And more people are more in favor of prescribing fluids regularly for the period of overnight fasting rather than preloading just inside the operation theater. As you all know, the reasons why we have a preoperative deficit, there is a poor water intake. The moment you say that you are going to have a major surgery, most patients don't take anything to eat or drink. There is a bowel preparation, especially when you have a bowel surgery. And then major inflammation can be associated with the stress response, which again leads on to the requirements, negativating the deficits again. and a hemorrhage that was there in the preoperative, like for example, a patient who was having bleeding, just aggravates this deficit. So it is important that we keep in mind when prescribing fluids during the preoperative phase. Intraoperative period, there is a tendency, the recommendation is to try and avoid large volumes of crystalloids. And Banstrup et al. Came with the multi-center RCT, which says restrictive fluid therapy is better in major colorectal surgery. But one of the things that the new guideline does say is when there is an ongoing need in the theater, in the operation theater, it is better to address it. So ongoing needs have to be addressed, and too much or too little is deleterious. That is why I came up with the title that just about even is where we need to go. And most of them are against using very rich, sodium-rich fluids and giving a lot of water. A zero balance with a gold direct therapy, fluid therapy would be the gold standard soon. In the postoperative period, it is time that IV fluids that we prescribe, both inside the operation theater, in the preoperative phase, and in the postoperative period, have become determinant of outcomes. The restoring of the circulating blood volume is critical, but fluid management should not compromise healing. So if we have an optimal fluid management, you have efficient hemodynamics, the tissue perfusion and the organ perfusion is good, and this tries and avoids a positive fluid management. Colloids, better at improving cardiac filling pressures, but whether they can be used in the postoperative period, unless there is a massive fluid deficit, we have to think twice. Hydroxyethyl starch, doubtful use in sick patients, but in normal perioperative patients, it is considered to be safe. Slightly hypotonic solutions would be better than the hypertonic or even the isotonic solutions in the postoperative. Fluid overload in the perioperative setting, the wet approach has been the gold standard for years. We used to pump in fluids in the theater, and then we just used to get patients who become oxygenation-wise a little bad with edema, third spacing, and on top of that, we have bowel anastomosis, which used to give away because of fluid overload. Hypervolemia is necessary to maintain a little bit of organ perfusion during anesthesia and surgery. But the myocardial filling pressures and the cardiac pressures can increase, and this can aggravate the deficits also. And there is, because of the overfluid hydration, there is a decrease in colloid osmotic pressure and the increased cardiac pressures leading on to pulmonary edema and decreased cardiac function, and thereby compromising organ function and perfusion again. The atrial natriuretic peptide that is released can cause natriuresis and capillary leakage that can aggravate the problems again. In the ICU setting, fluids are the cornerstone of hemodynamic resuscitation, there is no doubt. But when given too much, there is no doubt that we have all seen worsening gas exchange. We have seen wet lungs. There is a worsening in renal function. And on top of that, there is a problem with wound healing also. Although wound healing regularly doesn't come in the medical ICU setting. Capillary permeability alterations are there caused by major infections and sepsis. So initially, we thought that giving fluids were good. But now what they have found out is that fluid balance on the positive side is considered now an independent risk factor for morbidity and mortality in patients who end up on the ICUs for longer duration of time. Inadequate resuscitation is not preventable always. So there is no reason in why we should think that just by not giving fluids, we are inducing an iatrogenic injury. Decreased fluids lead on to poor tissue perfusion and organ dysfunction. So we have to make sure that we give optimal IV fluids. And on top of that, inside the ICU, we should almost always think about the age of the patient, the comorbid conditions, and the current diagnosis. So depending on what the patient has come to the hospital for at this point of time, rather than just prescribing fluids blindly. And we should also understand that the requirement of IV fluids will change during the course of the illness. The disease pathology itself will make the requirement change. And each patient should have an individual fluid prescription, which is reviewed daily by one of us and is tailored to suit the change in the disease pathology. That is why in 2012, they introduced the term de-resuscitation or de-escalation, just like we use for antibiotics. It refers to the late goal-directed fluid removal from the body. It is done using diuretics, RRT, or net ultrafiltration. The late conservative fluid management also has come into play, which is it's an independent predictor for survival in ICU patients, where they are targeting 2 consecutive days of negative fluid balance in the first week of ICU stay. Almost all patients who come to our ICUs, they have the first hit or the insult, which is the infection of the trauma. Then they develop the systemic inflammatory response, which cause the endothelial failure, which leads on to the glycocalyx problems and disruptions, and then lead on to organ dysfunction. The fluid overload and the interstitial edema that are associated with the overhydration trigger the vicious cycle where the patient is not spontaneously able to revert back from the ebb phase to the flow phase. So this is where de-escalation takes a role. So we can use albumin plus diuretics plus or minus a sequential PEEP to contract the intra-abdominal pressures, or we can also use renal replacement therapy and ultrafiltration. And there is a problem with over de-resuscitation. We have to be careful so that we don't cause a neurological dysfunction or injury. That is why they try to define 5 steps in de-resuscitation. That is, we should define a clinical endpoint, which is an improvement in oxygenation, for example, and we should set a fluid balance goal for the 24 hours, that is a -1 liter in 24 hours. We should set the perfusion pressures and the renal safety limits. So if the perfusion pressures are not getting maintained, then we should think about vasopressors. If the patient has got a renal problem, then we should be monitoring the renal functions as well. And then each 24 hours, we should continue to reevaluate so that we can actually adjust according to the disease, adjust according to the way the disease is behaving. That is why this came up. That is the 4 phases of fluid therapy, the ROSE or the SOSD, where you have the resuscitation, optimization, stabilization, and the evacuation phases. Resuscitation phase, we are talking about a hemodynamic shock, where the circulating blood volume is low. So we have to try and maintain the perfusion pressures by flooding the patient with IV fluids. So rapid fluid boluses plus or minus a vasopressors. We end up giving around 3 to 4 ml per kilogram over 10 to 15 minutes, and then we end up repeating it. This stage of the patient, the fluid balance has to be positive, and early adequate fluid management should be there. In optimization patient, the patient is no longer in overt, absolute, or relative hypovolemia, but continues to be hemodynamically stable. So we should think about reassessment and to institute some monitoring so that we can decide what fluid and how much to give, so that we can maintain the adequate tissue perfusion and oxygenation in order to limit organ damage. Here, we actually change from early adequate fluid management onto a little bit of conservative fluid management. The monitoring that we try to institute are intra-arterial blood pressures, the central venous line, the echo, the ABGs. And there is a way of giving the fluid challenge, that is the controlled mnemonic, where you should decide what type of fluid you are going to give, whether it's crystalloid or colloid, whether it should be balanced or unbalanced, and what rate it has to be given, whether example would be 4 ml per kilogram or 5 to 10 minutes, and what objective are we going to gain. The macro would be a maintenance of the arterial pressure and the heart rate and the cardiac output. Microcirculation would be, maintenance would be change in oxygenation levels. And then they should set up the limits also. Okay, till a level of CVP this much, or till a level of PVPI this much, we can give fluids. That would be the fluid challenge. Stabilization is over a period of days. We should make sure that enough water and electrolytes are there to replace the ongoing losses that can be there, and the organs should be supported properly. Here, we would start thinking about initial stage, it was positive. Then we started about a little conservative. Now we would be targeting a 0 or a negative fluid balance. So we would be going from conservative fluid management to goal-directed fluid management. we should actually evaluate on a continuous basis whether the excess fluid can be removed. If there is spontaneous diuresis, well and good. If we don't have spontaneous diuresis, we might have to use diuretics or ultrafiltration if needed. And it has been recently shown that diuretics favor the recruitment of microcirculation, thus decreasing the diffusion distances and improving the oxygen extraction. So there is a role for diuretics that is slowly being used, although nephrologists still would disagree with us giving diuretics. Coming to a little bit about the fluids that are available, we have crystalloids, we have colloids and balanced IV fluids. Crystalloids are solutions that contain small molecular weight solutes. Example would be minerals and dextrose. And colloids contain large molecular weight solutes that would be albumin and starch. The balanced ones would be crystalloids or colloids that do not significantly alter the homeostasis of the ECF. The isotonic crystalloids are like normal saline. It has got a 308 milliosmol per liter. It increases the extracellular fluid, but there is no change in the intracellular volume. It is used as a fluid resuscitation solution, and it is also used as a solvent for many of the drugs that we dilute, but be very careful about hyperchloremic acidosis. Ringer lactate solution, again, it's a balanced solution. It is used in resuscitation and maintenance, but in liver failure patients, I think can cause lactic acidosis. The hypotonic crystalloids, dextrose solutions, or the hypotonic saline solutions, they are used to correct the free water deficit. Both can cause hyponatremia and cerebral edema. The hypertonic crystalloids, they are the 3% saline and the 5% saline. They are high osmolarity solutions. They increase the extracellular fluid and decrease the intracellular volume. It is used as a treatment for hyponatremia and cerebral edema, but the important thing is it can cause osmotic demyelination syndrome if given too quickly and if there is a rapid rise in the sodium levels. There are mixed and concentrated crystalloid solutions. The mixed solutions are dextrose in saline, where you use 5% dextrose in a normal saline, or there is an isotonic bicarbonate where you use soda bicarbonate with D5 water or sterile water. They are used for treatment of severe metabolic acidosis, but there is a risk of hypernatremia where there is an obligatory sodium load, can cause alkalosis, and obviously the high concentration of sugars can cause hyperglycemia. The concentrated crystalloid solutions, 8.4% sodium bicarbonate with 50% dextrose in water. The important thing to remember is sodium load and the alkalosis that can be caused. And hypoglycemia treatment is we use 50% dextrose in water. The colloidal solutions, high molecular weight, they remain in the intravascular compartment. They generate an oncotic pressure, so it prevents the extravasation of water and it prevents against the reabsorption also. There is a greater effect in the intravascular volume than crystalloids. The natural ones are albumin and FFP. The artificial ones are gelatins, the dextrans, the hydroxyethyl starch. So, to summarize, fluid resuscitation, if the patient is unstable, the first thing would be treat the cause, and glucose-free isotonic fluids would be the best. Adults, normal saline or ringer lactate, 500 to 1000 ml, that is half a liter to 1 liter IV boluses. Children, you end up giving around 10 to 20 ml per kilogram IV bolus. You can repeat these boluses, and if we are not able to get the desired effect, we should consider use of vasoactive agents, that is inotropes or vasopressors. And if there is an ongoing bleed which should be addressed, we should use blood products. Whereas if it is a stable patient, avoid fluid overload, assess for fluid responsiveness, that is a passive leg raising test or fluid challenges. A balanced crystalloid can be used 100 to 200 ml over 5 to 10 minutes. Children, it is 5 to 15 ml per kilogram over 5 to 10 minutes. And limit the changes in hemodynamic, it limits the changes in hemodynamic parameters and your urine output as the limits to which you end up resuscitating. Replacement of ongoing losses, you end up using you have to decide what the etiology is. Example, burns, pancreatitis, GI losses, the drains or the fistulas, or even polyuria, where you have high output renal failure or diabetes insipidus. You have to treat the cause and replace according to the losses, plus a monitoring of electrolytes, so that you can add these electrolytes as needed to the fluids that you use. Maintenance fluid therapy for adequate hydration and organ perfusion in patients whom the daily requirements are not met. The first line for all age groups, irrespective of whether they are pediatric or adults, is isotonic crystalloids with dextrose to prevent starvation ketosis. The isotonic crystalloids with no glucose when already on nutritional support. Electrolytes are to be added as needed depending on the deficiencies that we pick up during the monitoring of electrolytes on a daily basis. Maintenance fluid therapy in pediatrics, neonates calculate based on hourly rate based on daily requirements. So like for example, in a day one child, it would be 40 to 60 ml per kilogram per day, and then you give it as an infusion. In adults, it is 1 to 2 ml per kilogram per hour, and try and avoid a overload of fluids. This is just a table that I picked up from one of the sites. It actually gives a tonicity, the hypotonicity, and how much of the salt is also added. It's a good graph. To summarize, IV fluid administration, just like any other drugs, just like example antibiotics, you have to look for indications, contraindications, and then side effects. The indications, depending on resuscitation phase, replacement phase, or maintenance phase. Depending on that, you decide which fluid you want to use. And as for any other drug, you have to have a dose, a duration, and a de-escalation. If using crystalloids, prefer balanced salt solution, limit acid-base alterations and chloride load so that the acidosis is not caused, and albumin may be beneficial when using colloids. In the perioperative setting, maintaining of adequate organ perfusion and oxygen delivery is the keynote. And fluid restriction slowly is becoming as a standard of care. While we move from the operation theaters to the critical care setting, endothelial injury and permeability that is caused, and the fluid interstitial edema that results, we should be forgetting. And on top of that, whenever we use any fluid, don't forget the hidden ions, like for example, chloride in the sodium chloride, or the chloride in the KCl, or the sodium in the soda bicarbonate. Those are the hidden ions that actually give ionic loads to the patient. And an ideal fluid still does not exist. This is my alma mater where I studied, that is Calicut Medical College on the left, and on the right is Kasturba Medical College, Bangalore. This is where I practice my craft now, Lissi Hospital, and the guiding light, as always, at Lissi Hospital Anesthesia, Bino sir. I have known him personally as well, though I have not worked with him. Fresenius has been sponsoring this meeting. Thank you and greetings from all of us at Lissi Hospital.
Thank you, sir. Thank you very much for the wonderful presentation. It was like a narrating story of fluid therapy from the physiology to the clinical scenario. There are few questions in the chat box, so we will take up the questions first, then we will go for the discussion. What is the current concept of using colloid during intraoperative period?
If you are dealing with a patient in whom there are a lot of age-related factors and comorbidities, we would try to restrict use of starches, gelatin, and dextran. The safer option would be albumin. But whenever you use albumin, make sure that you know how much volume you are using, whether this volume can cause an overload or not. So albumin is probably the new in thing. But if you are using in the perioperative setting where the patient does not have major illnesses or is an ASA1 patient but has got a volume deficit, even a starch or any other colloid is equally good. That is what I learned over the period of reading in the last 1 week.
Another question is, any role of gelospan in perioperative period by Dr. Pankaj?
I think I have already answered that. There is a role, but depending on the patient.
Okay, what is the fluid recommended for neurosurgery cases intra-op and post-op period?
Okay, this is one thing where I'm going to have a fight regularly with my neurosurgeons. My set of neurosurgeons regularly want saline to be given. In the last 2 months, I think I have already picked up 2 or 3 cases of hyperchloremia. And it took a lot of convincing to them. But I would still say a balanced salt solution in neurosurgery is much better. But you can actually balance it. Instead of using just balanced salt solution, you can combine it with normal saline and try to avoid glucose as far as possible. That would be the best in neurosurgical patients.
Okay, sir. And current role of colloids in microvascular surgeries, especially in plastic surgery. It's a tricky question.
Yeah, the problem is there was a time frame when we used a lot of dextrans, thinking that it would work. In microvascular surgery and in plastic surgery, I would probably go with a little bit of fluid dilution, in the sense that a little hypotonic solution would be better, so that we don't have the flaps failing or we don't have any thrombus sitting in the pedicles. So even if a low hemoglobin is there, a little bit of fluid excess is there, it is okay. But the important catch is the excess fluid shouldn't be compromising the flap again. So an overload is also going to be a tricky one. So I would probably head on low hemoglobin in my plastic surgery, vascular surgery cases, and then see how they behave, and then address on a daily basis.
Then can colloid be used after crystalloids for spinal hypotension in cesarean section?
I think that is an area that has not been checked too much. But if the hypotension is not getting corrected to your vasopressors or to your volume infusion, I don't see any harm in using colloids. But again, you should make sure that the patient does not have any other illnesses, so that you don't compromise the heart, basically.
Okay. Then next one is, any ideal volume status monitor for perioperative use?
There are different agents. I didn't specifically touch on that because goal-directed therapy, fluid therapy, you have a lot of gadgets that are available these days. There are people who have started using different things, but depending on what the losses is, I would probably say assess the surgical field, and on top of that, assess the hemodynamics as and when it occurs, and then address accordingly. That would be better intraoperatively, especially intraoperatively.
Someone asked about what about preloading prior to LSCS?
I think I have already checked it.
Then next question is, how to give fluids perioperatively?
I think that's that has already been addressed.
Addressed, yes. Then better IV fluid in pediatric population.
Pediatric population, I think the recommendation now is use an isotonic solution, but make sure that you have a little bit of dextrose in it, so that there is a glucose need that needs to be addressed also. So isotonic solution with dextrose would be the fluid of choice in pediatric population.
Then another one is post-op fluid, isotonic or hypertonic?
I think it has to be isotonic.
Okay. That's all the questions in the chat box. Now, actually, if some of our members, if they want to ask questions, they can unmute and ask the questions directly. Please unmute and ask. There is one question for Vandana, madam. Is there any role of leg raising in asystole?
No, no role for leg raise.
No. So we have covered all the questions in the chat box. If there is any questions, they can ask directly to the presenters, speakers. If there is no more questions, we can hand over to our president, Shalu madam.
Thank you, Dr. Vinil, Dr. Vandana, and Dr. Rajiv for the excellent session. Thank you once again. Now over to Dr. Prema to propose vote of thanks. Prema.
That was a very informative presentation.